Hello, everybody, and welcome to the American Sleep Apnea Association mini webinar series. We are delighted to present to you tonight recognizing sleep apnea in children, and this is definitely a topic close to my heart. As a mother and a grandmother, I have had several people in my family with this, so we'll talk a little bit about that. Let me give you a heads up that in 2 weeks, we usually have these webinars in the evening, but in 2 weeks we're going to have one in the middle of the day. I believe it starts at noon, and it's the day before Thanksgiving, and we're going to talk about diabetics, sleep, and what to consider at the Thanksgiving table. Big bummer right before Turkey Day, but sometimes you can go into it with a little more information and maybe some new statistics or new data about certain things. You can go into it a little bit easier and maybe not have any problems. Okay, but we will have that posted on our website. My name is Mother T. They call me Mother T around here. My name is Teresa Schumard, and I am the patient advocate for the American Sleep Apnea Association, and I'm also the community leader for some of our areas at ASAA. We're very glad to have you, and if you are attending the live webinar, you may type your questions into the chat box, and we can go over them at the end of the slideshow. If you're watching the recorded version of this webinar, you may email your questions to asaa@sleepapnea.org, and I will get those. So, last week we had a really nice webinar that talked about sleep apnea, and this week we are talking about the population that probably gets talked to. Next slide, slide 3, Sean, sorry. Children are some of the least diagnosed and really do need to be diagnosed, and sometimes parents need to be the advocates. So I'm going to teach you a little bit about what that looks like, and talk about, first, we're going to talk about the sleep that is typical for a child at certain areas of their lives. 1 to 4 weeks old, brand new. You're having a newborn that's probably sleeping about 16 to 17 hours a day, with periods of wakefulness that last 1 to 3 hours, depending on how sleepy baby is. If you can, I know sometimes it's hard to even keep them awake for that when it's feeding time and you have to tickle their feet to get them to nurse or to get them to, be alert enough to pay attention to eat. Especially if it's a small child, that can be an issue. So during the 1 to 4 month period, children tend to sleep about the same amount of hours, but their night and day sleep cycles begin to kick in, and they're going to be sleeping a little longer at night. At 4 months to a year old, children still require between 14 and 15 hours of sleep every day. However, many are able to sleep through most of the night and take up to 3 naps during the day and evening. 1 to 3 years, 12 to 14 hours for these little toddlers, but often they get less due to the schedules of their parents and older children in the home, especially if they're light sleepers. They'll likely lose their early morning nap and early evening nap about this time, and they tend to only take 1 nap a day, to the chagrin of moms everywhere. And they give up that other nap. You can't get as much done then because they're awake. And from 1 to 3, they're into everything. So 3 to 6 years, 11 to 12 hours approximately of sleep a night. Younger children of this group may still require a short nap during the day, but they need to nap. The need to nap usually diminishes by the time they enter the first grade. So otherwise, sometimes you will see that occasional kindergartner with his little head down. He just can't stay awake, and sometimes that has to do with he can't get to sleep at night, and sometimes he just still needs his nappy. So anyway, children of this age group from 7 to 12 years, they tend to need about 10 to 12 hours of nightly sleep, but often they only get about 9 to 10 hours. And a lot of this has to do with school start times, and that's a whole other topic we'll get on sometime. And from 13 to 18 years, teens of this age require about 8 to 10 hours of sleep. I'd say closer to 10, but rarely get that full amount they need. The demands of schoolwork and after-school programs and activities often cut into their nightly sleep. They only get about 6 to 8 hours of sleep, and we're totally asking them to go to sleep at the wrong time for them. They're usually not really in their rhythm. They're not supposed to go to sleep that early, and they would, if left to their own devices, will sleep late in the mornings, like you can see it on the weekends. And mom and dad think, well, aren't they ever going to get up? Well, it's their rhythms that have changed during the teens, so it's not unusual. Anyway, next slide, please, slide 4. That is my little granddaughter on the side there, and she was a pretty normal toddler, except that I noticed when I'd have her spending the afternoon with Nana that she had a snore, and I kept telling her mother, the baby is snoring, and she kept taking her to the doctor, and the doctor that she went to said, oh, she'll outgrow it. Well, she was there where she has her surgery done at the bottom. She just had it, and she's 9. So I think that my daughter finally had, proven that. They did a sleep study, and so they proved that she had it. I was very worried all this time, though. But her behavior problems that showed up were just like ADD. She was very nasal. Like I kept telling her, and my daughter tried, but some doctors just really believe that the child will outgrow it. And it is what it is. You never know, and you trust what your doctor is telling you, but sometimes you might need to go to someone else. You might need to just rest assured and get a second opinion. Okay, we are going to talk about some of the signs of sleep apnea in children. Does your child snore? Well, 10% of them do. Do they show other signs of disturbed sleep, like long pauses in breathing, a lot of tossing and turning in the bed, chronic mouth breathing during sleep, night sweats? And where do those come from? Well, it's because they're just working so very hard to breathe. So, yes, they're going to sometimes break out into a sweat. You'll hear nightmares, where and night terrors where they cannot even be consoled. They'll have excessive daytime sleepiness sometimes. Unlike my granddaughter, who was hyper, some children will actually get the excessive daytime sleepiness and be falling asleep at school. Speaking about the behavior problems and attention deficit disorder and that sort of thing, a lot of the times a child will be labeled with ADHD, and really they should have had a sleep study first, because a lot of the times there's a sleep disorder going on. But I guess that society is changing, and more parents are becoming proactive and educating themselves, so that's a positive thing. I was very disappointed in in some of the physicians, but that may have been his schooling. So, but it was my granddaughter. Her trouble with paying attention and just incessant talking, it was all due to the fact that when an adult has sleep apnea, we get tired, but in some children they will respond the opposite and they will become very hyper. So these children have trouble sleeping, they have bedwetting issues, they have sleepwalking issues, and all these symptoms, especially the snoring, are possible signs of sleep apnea, which is more common among children than is generally recognized. It's estimated that up to 4% of children suffer from sleep apnea, and many of them being between the ages of 2 and 8. Next slide, please. Children can have craniofacial issues as a strong indicator of OSA. OSA can run in families with adenoidal face syndrome, which is also known as long face syndrome. This is little Mia, and Mia's father has the same issues with the structure of the face. So luckily, little Mia was then diagnosed at an early age because the parents were very aware. Since Dad had it and they knew what to look for, it probably saved her from a lot of issues later on in her life. So, but her tonsils were removed, and she has undergone 2 dental orthodontic procedures to help expand her palate and her airflow, and she uses a CPAP to sleep. Next page, please. It is what Mia has is an orofacial myofunctional disorder, or OMD. Orofacial myofunctional disorders are disorders of the muscles and functions of the face and mouth. OMDs may affect directly or indirectly breastfeeding, facial skeleton growth, development, chewing, swallowing, speech, occlusion, temporomandibular joint movement, oral hygiene, stability of orthodontic treatment, facial aesthetics, and more. So you see, we're not talking about, we just have a little snoring going on, and we have some major issues going on here. So please keep that in mind when your child is being examined, maybe by the dentist. If you feel that there's some sort of issue going on with them, ask the dentist if he has, and a lot of dentists are very, very knowledgeable about this disorder. So, give him a jingle and, say, I'd like to have my child checked for this. So these disorders may impact treatments by orthodontists, dentists, dental hygienists, speech and language pathologists, and other professionals working in the orofacial area. Next slide, Pete, please. Children with higher IQs were looked at by a study that was done at the University of Michigan. Dr. Shervin and his colleagues said that even children with higher IQs behave better when their sleep apnea is fixed. So the study of behavior in children with higher intellectual ability improves as much as that of other kids when they have had their adenotonsillectomy for obstructive sleep apnea. Many doctors will ask about the quality of sleep when children have problems at school. It should be the first thing that is asked. It really should be, because sleep is as important as diet, and exercise in our lives. And these little children, really have no voice, We have to do it for them. But new research shows that it's just as important to pay attention to how high achievers are sleeping. They are still children. So next slide, please. Right away, you're looking at problems in school. And when a clinician sees a pediatric patient who has a problem in school, they talk about sleep, according to Dr. Shervin. He said, we wondered if in high-performing children, do we still need to worry about snoring or sleep issues? And he was the co-author and neurologist and director of the University of Michigan Sleep Disorders Center. All children in this study, from low IQ to high IQ groups, improved at a similar level when their sleep and behavior were evaluated 6 months after the adenotonsillectomy procedure. Parents graded their child's behavior in such areas as inattention, hyperactivity, social problems, and perfectionism. Next slide, please. Risks of untreated pediatric sleep apnea. If untreated sleep apnea in children can cause mood disturbances, depression, learning deficits, ADHD, bedwetting, and developmental delays, and a small percentage of children inherit naturally short airways and certain disorders associated with shortened airways, including Down syndrome, Pierre-Robin syndrome, and then we already talked about the myofunctional, oromyofunctional issues with Mia's case. The rest of the snoring pediatric population is likely suffering from childhood obesity. We have a lot of children that are not getting as much exercise with all of the pieces of equipment that they have these days to not go out and play. Next slide, please. So important was this issue and so much more into the viewfinder of society that the American Academy of Pediatrics revised its childhood OSA guidelines in 2012. So it is called the Diagnosis and Management of Childhood Obstructive Sleep Apnea Syndrome. Should you need to have some information to take with you to a physician that perhaps is not hearing you about your issue with your child, and maybe this is your only choice with your insurance, I would go armed with this this paper from the American Academy of Pediatrics, and it's available on their website. All you would have to do is go to the AAP and type in OSA guideline, and it'll bring it up for you. And that would be aap.org. So in addition, the following recommendations were made by the AAP. Polysomnography, which is an overnight sleep study, should be performed in children and adolescents with snoring and symptoms or signs of OSAS. And if polysomnography is not available, then alternative diagnostic tests or referrals to a specialist for more extensive evaluation may be considered. That would mean perhaps you can't have a sleep study, they won't pay for it, you have no sleep lab in your town, what have you. You may ask your general practitioner or pediatrician to send you on to an ear, nose, and throat specialist. Remember, you can ask at the dentist. There are just certain ways that you can. If you would read this guideline, it will give you a lot more information than I can give you in this short amount of time for our webinar. But anyway, let's go to the next slide, please. This is a typical face in mouth-breathing children, and a lot of our little guys that are, suffering with sleep apnea in childhood are, looking like this, and this is, you can see that he's keeping his mouth open in view B, the lateral view. He is, he's having to keep his mouth open. Probably, keeping the chin down like that is allowing for, the uvula, if it is enlarged, or the tonsils. The little guy is having to breathe, and there he is, just sitting there, and he's got his mouth open, and that's not normal. You should breathe through your nose. Sometimes it's a learned behavior, but for the most part, Mother Nature asks us to breathe through our noses while awake and while asleep, especially while asleep, though. All right, next slide, please. Adenoid and tonsil removal is the first line treatment for OSA. Surgical removal of enlarged adenoids and tonsils, it is definitely the most success with it. In uncomplicated cases, the operation results in completion and elimination of OSA symptoms in 70 to 90% of children that undergo it. That's pretty good. Although generally an outpatient procedure, some children with chronic medical conditions like obesity or severe OSA or complications of OSA or other problems other health problems, they should carefully be monitored overnight following the surgery because breathing abnormalities may not appear until they go into the REM stage, which, is the completely relaxed period of sleep. And if the tissues are going to relax and occlude the upper airway, that's going to be the time. So this would be for several hours into the next extended sleep cycle after the operation. Now, that being said, you're talking, baby that just had surgery, so you would consider that there's going to be some postoperative swelling. So really look at your child in 4 to 8 weeks, during that period of time. You'll probably notice some quietness right away, but, really watch them. And if you can't stay awake, record them and see what, go ahead and, fast forward and see if you get to a certain point. When they get very still and they're not moving around at all, they might be in a REM period. So, fast forward to that time and see what they're doing. Listen to what they're doing. That will tell you. Now, some great insurance companies will do, a post-operative sleep study, but I think that's probably not happening too much these days. All right, post-surgical considerations. Next slide, please. CPAP is recommended as treatment if the adenoid tonsillectomy is not performed or if OSA persists postoperatively. Weight loss is recommended in addition to other therapy in patients who are overweight or obese, like we said before. Sometimes you can get a prescription for intranasal corticosteroids, and that would be an option for children with mild OSA where, they did not, rank for the surgery. I mean, it could be that they just, they weren't bad enough. But that doesn't mean that it won't get worse. So I would just keep an eye on it. I have 5 children and 9 grandchildren. You have to excuse me. I talk like a warrior. But I've been to plenty of, and I loved my pediatrician. We had the same pediatrician for all the children, and he was great and listened to Mom. So I can't really complain there. But I've noticed that my children have had some issues. I think it's probably a lack of education out there. So it's our job, parents, to get out there and educate. So if the surgery was not indicated or if the surgery does not fully resolve the symptoms, they might have to, order CPAP for the child. And, there's nothing wrong with that. Little Mia wears hers without a problem. And I know I said to her dad one time, well, how do you get her to wear it? He said, well, what do you mean? I just put it on her. She was so young that she didn't give them a problem. And she knows now that she feels very much better when she wears it. So she just wears it. No biggie. You'll find it. I think adolescents are the bigger problem. You know, if they're that age when you're trying to get it on them, it may be a little harder because, you know, it's a challenge because of the look and the feel and the stigma and all these things. But so, you know, and compliance is being a key factor in determining the success of treatment. We may have a little more work to do. For many children with that dramatic improvement, it's a motivating factor to wear them. Well, we are at the question period of our webinar, and I'm going to share a few questions with you that came up with another group, and it was a group of parents. So I'm going to just read you a couple of their questions and their comments and see if you can relate to this. And then we're going to open up the mic, and you will be able to talk to us and ask your question that way, if you have one, or if you just want to make a comment, we'll be, you know, happy to have you. But let me read these few questions quickly. These were all parents from different stages of, let me get my okay. Okay, I'm there. My computer is freezing. Okay. This came to me from another group. I told you that. My 19-month-old has the malformation type of issue. It is where his cerebral tonsils sit in the opening of his spine. I read a research article that 70% of people with sleep apnea are Chiara patients. I'm taking him to get a spine scan to see if fluid buildup is causing his symptoms. So this poor little guy has got some issues. My son is 2.5 and was diagnosed with sleep apnea a few months ago by his preschool teacher. He has always snored really loud and gasped between very irritable while sleeping at night. We took him to doctor who is pediatric sleep specialist at UCLA, and she confirmed that his sleep apnea was there and that he needed to have surgery as soon as possible. And she reports that it was the best decision they ever made, that the child is, just doing wonderfully, not having any issues with his sleep. And he only complained about his mouth hurting for the first 3 days. That was my granddaughter's. It was the same way. Let me go down here to another one. This one is pretty good. I have believed my son has had this for about 6 months. We have not had a sleep study done as the doctor does not believe that he has it and has not yet referred me to an ENT. It is frustrating to know that my motherly instincts are being contested by a doctor who does not live at my house and has never watched my son sleep. I watch him sleep sometimes for over an hour. He snores, he gasps, coughs, breathes, and only breathes through his mouth and sweats profusely. I've had so many nights where his sweating has caused me to change his clothes and sometimes even his sheets at night. Poor little guy. And in 1 hour period, he got up to like 15 times, which for a baby, more than one is too many. That's really. I mean, these are babies. Where he doesn't breathe for 15 to 18 seconds. Then he coughs or snores in his next breath. And she says, I'm sorry that I am ranting so much, but it is so frustrating. My doctor has said that his tonsils and adenoids are severely enlarged, but that he will outgrow it. Well, so he suffers until then. I don't know. My daughter has had severe sleep apnea and has had her tonsils removed for 1 year. Most doctors prefer not to do this surgery until they're about 2. But after my daughter did a sleep study, her surgery was scheduled immediately. She woke up 154 times to breathe. Other signs of this were snoring, waking up, the whole gamut. The recovery was a little rough, but she sleeps great now. It was totally worth it, Mom says. Sean, let's open up the questions. Hello, everybody. Can we go around the room and say who's here? Just say your first name if you want and your city.
Edna from Queens, New York.
Hello, Edna. Thank you for joining us.
Thank you.
Do you have a little one?
Not that little. She's 12.
She's 12. But were you curious about her sleep?
Oh yeah, she does a lot of snoring. She makes a lot of noise when she snores.
Mm. Do we have anybody else here? Don't be afraid to join. It's okay if you don't want to.
Hi, Teresa. This is Adam in Florida.
Hi, Adam.
Hello.
And Carl in San Diego.
Hello, Carl.
Hello.
Edna, have you
Maybe
had...
Sean in San Diego.
Sean in San Diego. So, Edna, do you have, did you get any medical report for your daughter, or has anybody said anything to you about it?
Yeah, we had an appointment last week for ENT, and they were going to do an evaluation.
Mm-hmm.
So
a sleep study evaluation?
Yeah, sleep study evaluation. But he says that since it's just beginning the loud snoring, he's going to give it some more time. He just don't refer somebody just right away.
Mm-hmm.
So we on standby waiting for.
Is she
I got to write how many.
Daytime?
I'm sorry.
Is she sleepy in the daytime?
No, not at all. But when she goes to sleep, she could be sleepy for a long period of time. Sometimes on Saturday, she don't get up until 1 o'clock in the afternoon.
Yeah, sometimes that happens when they're teenagers or going into the teenage years. Carl, do you want to talk to Edna about her? Don't you have a daughter that's 12?
15 now already.
Oh, my goodness.
Yeah, and at about 14, we started to see the circadian shift a little bit, where it was hard for her to go to sleep at her normal bedtime of 8:30 or 9, and she really couldn't get to sleep before 10 o'clock at night. So yeah, there's definitely a circadian shift that happens in the teenage years. 12 might be a little on the early side, but it can happen pretty soon thereafter.
Oh, wow. Thank you.
Yeah.
Well, I'm just glad that you took her to get screened or to see about it. Because a lot of people just, they don't know to do that.
What did the doctor say to wait to see about what? I didn't quite catch what you said, Edna.
Yeah. Because I've been noticing this for the last 2 months. So he says rather than him referring her out to a specialist, he'd rather just wait a little bit more. So he gave me an appointment in December.
Huh.
at least that's at least around the corner. You know, one response you could tell him is he doesn't need to wait because you've been seeing this go on for, you know, you should always feel comfortable with letting them know for how long you've seen it, because that's more important. If you've seen her snoring and making those sounds while she's asleep, you know, for months or years, whatever your time frame is, just make sure you communicate that to him. At least December's not too bad, though. If he said wait till next springtime, I would say give him a call back.
Yeah,
and say,
yeah.
We need to speed this up.
You know what, Edna? You could take a little movie of her if you have a cell phone that can do that, and take it with you to the doctor.
Oh, that's a good idea. And I could
my
video
daughter
tell my
finally
daughter.
did this.
Yeah?
My daughter finally did that, and that's when our baby got her tonsils out. I said, see? I told you. I kept telling her, but, you know, nobody wants to listen to their mother. So.
Oh, I see. And doctor always thinks that they're right, you know, even though we're the mom and we watch everything that happens,
right.
They'll figure, you know, let's just give it some more time. That's the special word.
Yeah, well, you're the mommy warrior. You are the child's protector, and you know best. Your instincts are doing it. You know, it's why you took her.
Yes.
Yeah, and you know what's important about that's exactly right, Teresa. And what's important about sleep apnea and snoring is it's not going to go away. Usually it's related to the anatomy, and that doesn't necessarily change for kids. I mean, weight can be a factor. And if that's a factor and there's big weight loss, it's possible. But watchful waiting, it doesn't work for sleep apnea. So it'll be good to get that test and see where she's at. Yeah.
Let us know. You have the email address. Let us know sometime, or just come on our website and let us know, Edna. Because I'm curious. I'm always curious when these stories come about. You know. Like what happens?
Yeah. Exactly.
Sure, no problem.
Well, you hang in there. If we can be of any help to you, and if you want to take those, if you want those guidelines, I'll send them to you. If you want to write to the number that's on the bottom there, I don't know. Is that slide up there, Sean, where the email is? It's asaa@sleepapnea.org. You can write to us there, Edna.
Oh, okay. Okay.
If you can't find the web, we're on Facebook and we have our web page. We're all in a lot of places. But asaa@sleepapnea.org, you can just let us know. You know, that would be great.
Thank you. Yeah, thank you.
I hate to see her starting out in her teen years with, you know, with the problem that can be avoided.
Yeah, you're right about that.
Well, do we have any other questions or comments before we still have time? We went quickly.
You know, Teresa, something to mention that I think is pretty important that I think there's a lot of studies out of Taiwan and the sleep doctors at Stanford have been doing is that they've seen with a lot of children, especially after puberty, had their tonsils and adenoids out before, but they all became mouth breathers because they never were retrained to breathe with their nose. And that's a big part of what the myofunctional community is trying to do. So, you know, your airway really stops growing at puberty, and it's sort of putting more pebbles around the river as you get older and you put more weight around your neck. So that's really the time when, for me personally, when I started to incrementally go downhill and didn't even realize it, because my tonsils and adenoids, thankfully, were taken out at a young age. But that's not the case for a lot of today's children, especially in their teens right now.
Yeah, you know, there was always this thing, like in the later years, oh, no, don't take their tonsils out. They need their tonsils. And I never understood that because I was 6 years old when they took mine out. I mean, My sister was with me. She was 3. We had the two of us in there had our it was like family day, or whatever. But they didn't even blink twice, in the in the 60s when they had a child. They just took the tonsils out and the adenoids if they needed it. And I stopped having colds and earaches and stuff. So but
that's what was so interesting about those studies in Taiwan, is that they saw from like 13 to 18 the kids, slowly were getting sicker, the grade performances went down, all sorts of other outcomes that were reported. But it was clear that tonsils and adenoids are one intervention, but there's a multidisciplinary intervention to treating and managing this, and it just doesn't happen at one time. It happens over a period of a long time, and it's something you have to monitor. But thankfully for someone like Edna, she's on it, when her daughter's at a relatively young age. And Edna, my advice as a parent and as a layman is, if you don't necessarily like the answers you're getting from your own healthcare professional, use your mommy intuition and find someone who will listen. That would be my best 2 cents for you, because if you've witnessed it and you've seen it, there's no reason to wait to go. I mean, it's nice that you have an appointment set up. We're happy to hear that, but definitely don't let that go without further actions.
Yeah, thank you.
Yeah, just believe in yourself and your intuition. Always listen to that.
I had many doctors, many pediatricians told me that I was crazy when I brought my daughter in because she didn't fit the classic stereotype. Unfortunately for me, it was, as a parent, I saw what was going on, and if I could avoid this in my own child, regardless of the damage and the outcomes it did to me, it was, nothing was going to get in my way. And I can't say that everyone agrees, but you start to find the people that can help you and move you along the right path, even in this crazy healthcare system that we have to learn to navigate, which makes it even that much harder.
Oh, I'm sure that has 80% of the problem is that, probably,
Well, it is. You've got a profession and a field that was educated on sleep deprivation being a badge of honor, and when we grew up, snoring was cute. Look in the cartoons, look in the TV shows. People laughed at it, so they don't take it serious. So that's part of what we have to do as an association, is change the messaging about that and teach mommies that it's not cute, it's not funny. It's a warning sign. It's a red flag.
Absolutely.
Yeah, completely agreed.
Well, I would like to thank everybody for being here tonight, and we look forward to seeing you on Thanksgiving Eve. I'm going to get the date here for you. That would be the 21st of November, and it's going to be at noon Eastern Time. And we're going to talk about choices for the diabetic Thanksgiving table and your sleep. So until next time, thank you, and have some good sleep.
Thank you. Have a good evening, everyone.
Well, I think we'll have more mommies at a noontime webinar than we will at an 8 p.m.
Yes.
one.
Yes. This is the prime
Thanks,
time
everybody.
to get the babies ready, yeah.
my wife's putting my baby to sleep. Goodbye.
Bye, Edna.
Okay, take care.
You too.
Have a good
Bye-bye.
evening.
Take care.
Okay, bye-bye.